One of the interesting things and one of the frustrating things about lymphedema related to breast cancer is that while the risk is quite large, it's very difficult to define who exactly is at risk, insofar as approximately 25% of the patients who undergo axillary lymph node dissection or radiation therapy or both will ultimately develop lymphedema, but we cannot prospectively identify who belongs in that 25% high-risk group versus the 75% who don't. And the other frustrating element is that the time to development of overt lymphedema is quite variable. Most of it occurs within the first 36 months, so about 90% of that 25% of patients will manifest clinical signs of lymphedema within 3 years, but it is at a very variable rate that it'll appear. Some will appear almost immediately within weeks or months of the surgical intervention, but many, many will appear even after the first year. So it seems prudent to monitor patients who are at risk by virtue of surgical interventions or radiation therapy or both quite frequently, at least over the first 3 years after the surgical intervention. And the difficult issue for clinicians is that that risk is not predicated upon the direct surgical intervention, and it's not predicated on necessarily the number of doses of radiation. It's simply predicated on the presence of those variables. And it appears that other variables in the patient will determine the overt and measurable risk over time, so that we really don't have a good way to predetermine who's going to develop lymphedema. It is a risk that's out there for the entire breast cancer patient population, and most particularly the ones that have had combined treatment with surgery and radiation therapy.